Hey, Paul. My friend has fallen head over heels for a new girl. She's only a humble whiskey maker, but he loves her still.
That's not bad. Matt, I was talking to a Frenchman, a man from France, and I asked him if he liked video games. And do you know what he said to me?
I don't know.
Oui. I feel like that was pretty solid.
Yeah, okay.
All right.
The Curbsiders podcast is for entertainment, education, and information purposes only, and the topics discussed should not be used solely to diagnose, treat, cure, or prevent any diseases or conditions. Furthermore, the views and statements expressed on this podcast are solely those of the host and should not be interpreted to reflect official policy or position of any entity, aside from possibly Cash Like More Hospital and its affiliate outreach programs, if indeed there are any. In fact, there are none. Pretty much, we aren't responsible if you screw up. You should always do your own homework and let us know when we're wrong.
Welcome back to the Curbsiders. I'm Dr. Matthew Frank Watto, here with my great friend and America's primary care physician, probably the primary care physician, Dr. Paul Nelson Williams. Hey, Paul, how are you doing tonight?
I'm great, Matt. How are you doing?
I'm doing well, because this is a digest episode. It's been quite a while since we did one of these. We got some great articles to talk about, some practice changing, maybe all of them practice changing. We'll decide in real time. And we have two great friends with us to help us do this, Paul. But before we introduce them, or before you introduce them, remind people, what is it that we do on Curbsiders?
Sure. Happy to, Matt. As a reminder, we are the internal medicine podcast. We use expert interviews to bring you clinical pearls and practice-changing knowledge. Most times, I guess that's still kind of the case this time around. This episode in particular is a little bit different than our traditional format. As you know, the digest episodes where we recap some of the articles that have been talked about in the Curbsiders Digest or maybe are about to be talked about or should be talked about. And apropos of that, we are joined by our fearless editor of the Curbsiders Digest, Dr. Nora Taranto. Hi, Nora. How are you?
Good. How are you guys?
Great. We already answered this. And we're also joined by Dr. Laura Glick, a hospitalist also and frequent contributor to the Curbsiders Digest. Laura, welcome to the show.
Thank you.
Nothing to worry about, Laura. This is going to go great. You're going to kill it. We're going to have a lot of fun. Paul's going to critique some trial names, and it'll be great.
Can't wait. This is reminding me of when I played doubles tennis in high school, and my doubles partner was named Laura. So Nora and Laura going here today.
I'm going to venture to say you could probably destroy Paul and I in tennis, because I don't play tennis, and I don't know if Paul does either.
I barely move if I can help it. So, yeah, it would be a bad scene, I think.
You're not a pickleball guy?
Are you asking me or Matt? Matt is a well-documented pickleball guy.
Oh, really?
I don't even know how to play it.
Oh, well, that was for you, Paul, but...
yeah, no, I don't even know what it entails.
I've resorted to soccer now because, I can't have too many hobbies, but pickleball, at some point I'll return to it for sure. All right, well, let's go to our first article, which, Nora, you will be presenting it, and I believe, is this the one that has the clever name? I think it does. The Identify study?
Yeah, exactly. This one is called Identify. Paul, what do you think that stands for? Knowing nothing about the study.
Huh. Yeah, I don't know how they managed to get cell-free DNA and identify it together in the same trial name. So I have a feeling it's probably just gibberish nonsense they mashed together to make it work. Am I mistaken?
You're on the right track there. It does have some I's and D's, but yeah. So it stands for incidental detection of maternal neoplasia through non-invasive cell-free DNA analysis. So I similarly couldn't really figure out how exactly they got there, but it's catchy.
Yeah, because there's not a Y to be found in that, right?
I think they used the Y from analysis.
Oh, the analysis. Oh.
Mm-hmm.
Yeah. And they used the E from maternal, but everything else they got. So I think it's decent, I would say. By your criteria, Paul, they got out of the 1, 2, 3, they got most, all the letters but 2. That's pretty good.
No, just listen, you cowards. Straight up acronyms, or just don't even bother. I'm so...
That's pretty much all I wanted to mention for this study. So I feel like we're done here.
I think we should apologize to the authors who are surely not cowards.
Yeah. Way to advance scientific knowledge, you idiots.
They should know how we read these studies,
Yeah, that's on them.
Okay, Nora. So tell us about this. Let's get to the meat of this. Let's talk about it.
Yeah, so this study is actually a really interesting study by Turif et al. It was published in the New England Journal in December and was covered by Dr. Jen DeSalvo in Digest 60. And this study looks at patients who had undergone prenatal non-invasive testing, or NIPT. And this type of testing uses circulating cell-free DNA in the mom, so in the blood, to look for fetal chromosomal abnormalities. And it's now covered by insurance mostly, and has overtaken a lot of the more invasive testing to look for fetal chromosomal abnormalities, like amniocentesis and chorionic villus sampling, which are two kind of more invasive procedures to look for these. And so these non-invasive tests, these blood tests, look for the free DNA that's floating around in the plasma of mothers-to-be, and looks for these fetal chromosomal abnormalities, but it can also pick up abnormalities in the mom. And when it picks up abnormalities in the mom, these results are most frequently listed as abnormal or non-reportable results, because they can't actually tell you anything about the fetal status. And so there are no guidelines, despite the fact that these tests are reporting out non-reportable results, as to what to do when you get a non-reportable result for a pregnant person.
Yeah, Nora, what the reason I was interested in this is because, there's these multi-cancer detection tests now that also look at cell-free DNA. And there's one out there that looks like for like 50 different cancer types and it's mostly recommended for people at like high risk for cancer, so adults over 50. But that's looking at like cell-free DNA in just the patient's blood, and it's looking for methylation patterns. But this is different. This is because it's mostly this is just like a total incidental thing, right? That they noticed that they were looking for these fetal chromosomal abnormalities, and they accidentally are finding maternal chromosomal abnormalities. So what types of cancers are they finding in the mothers when they get these results?
Yeah, and so this study followed 107 patients who were either pregnant at the time they came into the study or were within 2 years postpartum, and all of them had had this abnormal or non-reportable result on non-invasive prenatal testing. They looked at a couple of different things in cancer screening. They did whole body MRI. They did blood tests, including tumor markers. They did physical exam. And they also did a fecal occult blood test. And in the 107 patients, 52, so that's almost 50%, were actually diagnosed with a cancer. So that's quite a high number in this population that was screened for cancer. And the majority of those patients were diagnosed with a lymphoma, including Hodgkin's lymphoma in 20 of the 31 who were diagnosed with a lymphoma. The other 20 were diagnosed with solid tumors. So that includes colorectal cancer and breast cancer most frequently. And not all of those cancers were advanced stage. So some of them were actually slightly earlier stage. And then some of the advanced stage cancers were able to be treated with curative intent. So that's trying to get rid of them once and for all instead of just treating palliatively.
And they use the whole body MRI because they could do those in pregnancy without radiation.
Exactly. And they had a slightly different protocol for the postpartum and the pregnant individuals, but they were able to do whole body MRI for all of those patients.
Yeah. I think this is going to be more and more common as we get like for cancer screening, because this is just like, it's an easy way to screen a lot of people. I think the mess of it is, we were talking about this offline before we started, is like the what's the cost of this going to be? And you're going to find like tens of thousands of cancers if you do this in pregnant women, and then we're not really set up to get these whole body MRIs and to do all this testing. But since this test is already being used and now this information's out there, I think this is just going to, like, you're going to have to do something with these patients when you come up with these results.
Yeah, I think that's exactly right. And one of the points that they made about the population was that patients went about 10 weeks from a non-reportable result to entrance into the study. And so I do think there's probably a window to intervene and or at least just guidelines that should be established for providers who are ordering these sorts of tests about like what exactly is the follow-up that these patients should have. Is that like a multidisciplinary group of people trying to figure out what's going on? Is that some imaging baseline? Is that repeat sequencing that can confirm abnormalities, which they kind of got into in this study a bit as well to try to characterize the different types of patterns and whether or not there were patterns that were strongly associated with those patients who had cancer.
Paul or Laura, before Nora gives her final take home on this, any questions, concerns, comments?
Yeah, I guess one thing I'm thinking about is the practicality of implementing these results, and I'd love to hear what you think, Nora. But doesn't seem like whole body MRI is really an imaging modality that is commonly ordered by these providers or that would be covered by insurance. So I'm interested to hear your thoughts in terms of the practicality.
Yeah, I mean, I think that's the huge challenge here that this really doesn't have support to be implemented as it stands. That doesn't mean that for certain cohorts of patients who are high risk based on a test like this, that will continue to be the case in the future. But right now, obviously, kind of whole body MRI is not something that we're ordering. Even for our cancer patients, that's not something that we are ordering. And like PET scans can't be followed for a lot of cancer patients. So I think that's going to be the one big challenge, though I do think that if the various societies who are invested in this kind of get together and decide what the right workflow is of testing, then that might change in terms of insurance and the like infrastructure for it.
No, I really appreciate the point that I can see this test being ordered. You get the results back as now reportable, and your response being, that's weird. Not, 50% of these patients have cancer. That's, I think having some sort of mechanism in place just to make sure that they're triaged appropriately is obviously the next critical step. Because I think in general, from a technology standpoint, we're at this inflection point where we're going to be seeing lots of stuff like this, where we have these novel technologies and ways of screening for things that will have unexpected results that we don't quite know what to do with that will turn out to be important later. So I thought that was a great point on your part.
Yeah. All right, Nora. So what do you think? Is this ready for prime time? Is this practice changing, or is this sort of, to be tracked closely, however you want to categorize it?
I like that last category. I feel like most things I think about are in the to be tracked closely category. And this is definitely one of those. If I had the power to make these covered and to like create that infrastructure today, I would. But I do think I think that's coming and that there's need for that infrastructure. So I imagine it will happen in this specific cohort of patients.
Right. As someone who has a lot of cancer in their family, that is a top, like this sort of detecting cancer early by blood testing is something that I'm very interested in, and the whole body MRI and all that stuff. I know that's very, like certain groups of very wealthy people are just getting them every year just because, trying to detect early cancer. And it's definitely something that I think will eventually be more widespread, like as these technologies get cheaper and, we know what to do with the results. We get like processes in place. So good one to choose. All right. So next up is this one, Paul. Paul, are you using any vitamin K2 in your practice?
I think you'll mention it, but I've been advocating heavily for pickle juice, but I have not made the transition to vitamin K2 yet.
All right. So this is so in digest number 59, Hannah Smith covered an article by Tan et al. On vitamin K2 in managing nocturnal leg cramps. And this was a randomized controlled trial. It was in JAMA Internal Medicine in December of 2024. And as Paul mentioned, we've talked about leg cramps on the show going way back with Joel Toff. And then we talked about the pickles randomized controlled trial, which was done in patients with cirrhosis using pickle juice or pickle brine. And that was by our friend Elliot Tapper back in 2022. And now this is vitamin K2, also known as menaquinone 7 or MK7. And this was previously studied by the same group in patients on dialysis, and they had positive results, which was surprising and just really intriguing. So Nora, as a blood doctor, what do you think about this?
Well, I feel like my first instinct was I was a little worried about the warfarin component of this and the vitamin K antagonist part, but was reassured by reading the study and looking at the prior studies, though obviously they excluded patients who were on vitamin K antagonists.
Yes, they did. So this study was a randomized, double-blind, placebo-controlled trial, and they were giving patients one capsule of 180 micrograms of MK7 at night, or they were giving them a placebo that looked pretty much identical. And the patients were 65 and over, and they had to have at least 2 episodes of nocturnal leg cramps in the 2 weeks prior to enrollment. Then they gave them either the drug or the placebo, and they followed them for 8 weeks. And then they looked at what was the difference in frequency, severity, and duration of leg cramps in the groups. And the frequency at baseline was not that high. It was about 2.6 or 2.7 leg cramps per group in both the placebo group and the treatment group. And then curiously, during the study, the number of leg cramps increased in the placebo group and decreased in the K2 group, the treatment group. So there, at the end of the study, there was a reduction by about 2.67 leg cramps, nocturnal leg cramps, which was deemed to be significant. And then they also looked at the severity, which wasn't that severe. It was like a three and change on a scale of 1 to 10. It was like a 3 at baseline, and it decreased slightly in the K2 group versus placebo, and the duration also decreased a little bit. So overall, this was a positive trial. And any questions, comments, concerns? Paul, you look like you have something to say.
No, I just to clarify, the numbers that you're throwing around, like the 2.7 and 3.1, these are, I think, leg cramps per week. These are weekly episodes. I just want to make sure that we're actually getting the numbers right, because that wasn't exactly clear to me until I sort of dug deeper, because I wasn't quite sure how they were quantifying.
Yeah, mean
leg cramp
weekly
production.
nocturnal leg cramps. So it's like
Okay.
episodes. So they were having, between 2 and 3 episodes, 2.67, but when they averaged it out, but it was so 2 to 3 episodes per person over the 2 weeks prior to the study on average. And if they were having less than that, they weren't severe enough. They weren't included in the study. Anything else, Laura? Have you used this, or have you come across this in your practice? What did you think about this one?
Honestly, I have not come across it at all. I do think it's interesting, and I think you have to be careful because nocturnal leg cramps, they can be incredibly uncomfortable, but they're overall generally benign, especially if, the severity that the study talks about. And I think the results are promising. And K2 is widely available and inexpensive, so and an overall promising safety profile for most people. But I do think you have to be careful because it's something that should be very safe given the benign nature, although very bothersome, of nocturnal leg cramps.
I think that's a good point. And so a couple things about this, like the mechanism, they're not exactly sure how it works. They think maybe it has something to do with calcium and muscle contraction, but you're not really sure. So in order to prove that, something works, there has to be at least a biological plausibility. So I think that's a big piece that we're missing for this, but there is at least a theory as to how they work. And then another one is just that was this a really highly selected population? So they excluded about a third of the patients that they screened for the study, mostly because they didn't have at least 2 cramps in the 2 weeks leading up to the entry period. And then some people were excluded if they had like specific metabolic conditions that would cause the cramps or neuropathy. And they excluded patients who were taking diuretics, which for me would exclude a lot of my patients who have leg cramps. So that would be a population that I would really want to know if this works for. So that being said, I mean, my take on this was they really did not find any adverse events. As long as the person's not taking a vitamin K antagonist like warfarin, then I don't see the harm in trying this. It looks like it's relatively cheap. You can get the tablets come in between 100 and 300 microgram tablets. I don't know if you can find 180 microgram tablets like they used on this in the US, but people can look around. But to buy, I could tell a patient that has nocturnal leg cramps, buy a bottle, try it out, see if it helps. If it doesn't, That's fine. They did see a reduction in cramps pretty quickly in this. So, they don't have to do it for more than a month or so. So I think it's worth doing. What about you, Paul? Are you, as America's PCP, will you be recommending anyone try this?
I'll probably give it a shot, right? Because I think both of her points are really well taken. Like, first of all, you want to make sure that your interventions are very low harm because these are not going to kill people. But on the other hand, these patients are miserable. And if you think about the downstream workup of someone who comes in with leg cramps, you're checking lights. You're probably checking a TSH. Why? I don't know, because we check a TSH for everybody. Like, you'll throw in a ferret in there because why not? Maybe, God forbid, you're doing like low-dose gabapentin at nighttime, just throw it against the wall, see what sticks. Their legs swell up or they fall out of bed. Like, so, these are, even though it seems like a minor thing, like I hear this all the time, there is workup that goes into it. So if there's a low-cost, low-harm intervention that may actually be effective, that's actually really fabulous news, because I feel like I run into this in primary care a lot. So I was actually excited for this one.
One interesting thing that I just was thinking about, because I did
Stormy Toronto.
Yeah, get excited. I did go down a rabbit hole of like trying to understand what vitamin K is and what vitamin K2 is in particular. And there's a nice review on like vitamin K in the human body and physiology if you want to do that. But do you know what foods vitamin K2 is in?
Leafy greens?
No. So K2 is in like fermented foods and like soft cheeses, eggs, meats. And I just looked it up, and I think there is a decent amount of K2 in pickle juice. So,
ooh,
interesting.
Then the authors didn't even put that together. Nora, that's
wow.
I think we might need to write this up.
Yeah. I mean, this is literally just based on Googling vitamin K pickle juice. So I'm not sure how good the evidence base is there, but
do you guys hear that ringing sound? Does anyone else hear that? Because I think it's the Nobel Committee calling.
Thank you.
It's very exciting.
Okay. All right. So that's enough on that one. Paul, I think, Paul, you have one to talk about, and I don't, does this one have a clever name? I don't know. I
could not find a fancy pants trial name for this.
Missed opportunity. All right, Paul, what are you talking about?
So we're talking about as-needed blood pressure medications and adverse outcomes in VA hospitals, an article that came out this year in JAMA Internal Medicine. So as you know, we've been banging this drum for years, like literally years at this point now, at the use of PRN anti-hypertensives for hospitalized patients with asymptomatic hypertension. This is a group that by and large, it's about 70% of patients that are hospitalized have elevated blood pressures, and many of those patients don't have a diagnosis of hypertension. There's lots of reasons to be hypertensive, whether it's pain or volume overload or medication effects and on and on and on. And yet still, this practice persists of having like order sets with PRN anti-hypertensives to give for blood pressures greater than 180 systolic or whatever. So this is yet another trial to kind of look at, are there harms associated with this? And not to give away the game, but yes, there are. So it is a retrospective cohort trial, but it is a emulated trial. So the way these work is they actually emulate a randomized control trial using information from retrospective trials that kind of meet their specific needs. So it's kind of a nifty design looking at hospitalized patients at the VA system. So these are overwhelmingly male patients for what it's worth, and looked at data between 2015 2020 and patients admitted but not to the ICU. And they even included cardiovascular admissions, which previous studies do not always do. So you have a little bit more data that is useful to work with and a little bit more reflective of everyday practice. And so they did this trial emulation looking at two groups that received PRN antihypertensives and patients that did not. Pretty straightforward. And their primary outcome that they were looking at was time to first acute kidney injury event, which I think is an interesting one, but it also makes sense because I guess it's relatively easy to kind of chart mine and kind of find that kind of detail out. And that, in case you're interested, is a rise in creatinine greater than 0.3 milligrams per deciliter from baseline within 48 hours, or 50% increase over 7 days. And they started watching the day that you actually gave the as-needed blood pressure medication. So I'll pause here to see if there are questions or thoughts or predictions as to what may have happened to compare between these two groups.
I mean, I mostly have comments on the outcomes of this. I thought it was neat. I hadn't really, this emulated trial design I thought was pretty cool, reading about how they did that. And I mean, I don't know, Paul, this was a VA population. It was mostly men. I mean, that's obviously that's going to be a setup for some kind of limitation. And then we had talked about this a little bit before. Their composite of MI, stroke, or death was based on the discharge summary, and then the way they determined if the MI or stroke happened during the hospitalization was if someone remembered to check present on admission when they were like categorizing,
It's bulletproof.
Yeah. So it seems like they might have miscategorized or maybe even missed some events because, sometimes you'll get a discharge summary and it says like just one thing on it. And you're like, there was a lot more that happened that was addressed during that hospitalization. So maybe the VA system's different, but sometimes I'm seeing discharge summaries missing some of what has actually happened in the hospitalization. And then the AKI definition, creatinine rise of 0.3. Do we always really care about that? So I would have. That's a little bit of a soft endpoint, and if that's your primary outcome, it's a lot easier to show than if they said like doubling of serum creatinine or 40% increase in serum creatinine. Some of the ones that we see in some of the major adverse kidney event, included as a major adverse kidney event in some of those renal trials.
Yeah, all well said. I should probably just give you the outcomes so that your comments make a little bit more sense in context. So they looked at 130,771 veterans that were included in this acute kidney injury analysis specifically, and 20% of those folks actually received as-needed antihypertensives, just to give you a sense of how common this practice is. 18% received just IV only, 66 received oral, and then 15% received both. And then they actually looked at sort of subgroup analyses in terms of outcomes with these. And not surprisingly, the patients that received IV only PRN antihypertensives had a 64% increased risk of actually having the acute kidney injury. But all groups had an increased risk of acute kidney injury. And not surprisingly, these patients also are more likely to have rapid drops in blood pressure as well. And again, less surprisingly, more likely to have the composite outcome, as you say, which is when you're doing this sort of chart mining retrospective review, you're limited in terms of what to do with that information. And like even the administration of the PRN antihypertensives, like you can do all the matching you want, but it's kind of hard to know. Sicker patients probably need more medications and have more variability in blood pressure. So there's going to be some confounding stuff in here. But in general, I think this sort of adds to the body of evidence. This article itself refers to 3 other articles that were done in 2021 that looked at the same thing in terms of outcomes and intensification of blood pressure. And every time you look, those patients do worse. So it seems to be, this should be a practice that is hopefully going away at some point.
Well, we have a hospitalist with us. Laura, what are you seeing and what do you think about this?
Yeah, definitely. As an inpatient clinician, I see this all the time, and this as needed antihypertensive medications, either as kind of a one-time dose or even as a recurring as needed medication. And I think this is yet another study showing that we should be treating the patient and not the actual number. And I think, like Paul said, there's usually a lot of reasons that hospitalized patients are hypertensive, and investigating why the patient is hypertensive, or maybe hypertensive should be the first step. It could be, is it related to sleep? Is it related to anxiety in the hospital? Are they withdrawing from alcohol or a substance? Could it be other medications the patient is receiving? Are they on steroids? I could keep going for a while. And the truth is I receive pages all the time for this type of asymptomatic hypertension. And I think it's very easy to reflexively respond by ordering an antihypertensive medication to feel that you are doing something, both for you, for the patient, for the nurse, for everybody involved. But it is so, so important to realize that the use of these as-needed blood pressure medications may actively harm the patients. And I think we've seen studies over and over again that show that this is harmful. And I think we really need to be careful about doing it, as needed at any point if they're asymptomatic.
Well, I still think, Paul, this is as much as you berate people when they do this, presenting patients to you in the hospital, this has been a tough practice to crack because there's no shortage of writing about how you should not do this, how you should look for why the blood pressure is elevated. But I don't think this article is going to be the final nail in the coffin of this practice, but it should hopefully be one nail in the coffin that will eventually, close this practice.
I think the needle's moving a little bit because I will say that I think I posted about this article on Blue Sky, if I'm not mistaken. I was like, hey, this by the way, PRN antihypertensive is still bad. And someone, it was either an early resident, I think it was a resident, replied, wait, people are using PRN antihypertensives in hospitalized patients. So like at least in one place, like that is a surprising thing to do. So hopefully it is, I'm going to count that as an encouraging sign that this is slowly falling out of favor, but not really quickly enough.
I do wonder whether this is something that we need to think kind of intentionally about spreading, not only on like the medicine floors, but also elsewhere. Obviously, this specific study didn't actually include, or they excluded surgical patients, but I do think that's probably a big area where we could could improve our education around this. And I'm sure that a big part of that is just people aren't aware of the many studies now that have looked at this.
And I think also the emergency department, it's just such an easy thing to give without really thinking about kind of the harmful downstream effects. And I think it kind of makes everybody feel better in the short term, but that's not always the answer.
Yeah. I think you have to build it into the electronic record. Like, hey, are you sure you want to give this? Did you check for this, this, and this? You know, that you could put some things in there that make it an easy decision for the person or maybe scare them off from doing it. But who knows? All right. Well, Paul, any final comments before we go on to our next article? I know you're dying to talk about this one as well.
No, let's move on.
Okay. So Laura, what are you looking at? And I didn't look to see if this one had any clever name. I don't
No
think it
clever
does
name,
either.
unfortunately. You can make one up, but it does not have one.
Well, I think we chose some good topics tonight, Paul, but we really missed out on these. Like, we only had one clever trial name so far. So hopefully,
It's we got some show left. There's
All
still a
Maybe
chance to
maybe
save
the
it.
future
there's one
randomized
more.
control trial will have a name.
Yeah. Okay.
Yeah, so this is looking at GLP-1 agonists and looking at the potential benefits of GLP-1 agonists in patients with alcohol use disorder. So this is a recent cohort study published in JAMA Psychiatry. And in this study, researchers used a within individual design to study whether GLP-1 agonists could decrease the risk of alcohol use disorder-related hospitalizations. So the researchers examined data from a national registry in Sweden and included over 220,000 patients ages 16 to 64 with the diagnosis of alcohol use disorder. The median follow-up was 8.8 years, and the results showed that semaglutide and liraglutide use, but interestingly not other GLP-1 agonists, was associated with a significant decrease in the primary outcome of alcohol use-related hospitalizations, as well as secondary outcomes, including a decrease in substance use disorder hospitalizations and somatic hospitalizations. And they did not see a significant change in risk of suicide attempt. And I'm interested to hear your thoughts. I'll stop there for now.
You got to go to Paul for this.
No, this has been an exciting area that has been looked at for a while now. People have been talking about and excited for it. I think the data are mounting that this is plausible. There have been animal studies that have shown it reduces sort of alcohol cravings. There have been a couple of retrospective studies that came out. There was one in October of 2024 that made a lot of sort of popular press. That was also a retrospective cohort study done in the States, not in Sweden, that also showed kind of similar outcomes. So it's an exciting area that I think probably has biologic plausibility and is certainly worth exploring. I'll have a bazillion other thoughts, but I think I'll pause right there.
Yeah, I think interestingly, the approved medications for alcohol use disorder, including naltrexone, disulfiram, and acamprosate, were associated with only a modest decrease in alcohol use-related hospitalizations with an adjusted hazard ratio of 0.98. So they saw much more benefit from the GLP-1 agonist in the study.
Yeah, and
we didn't see how the two did together, right? In this study, at least, if you're on both a GLP-1 and naltrexone or disulfiram.
Right. So with this study design, that you can't tease out exactly the specifics.
Yeah, this was an observational study. I think it would just be hard to the type of patient that typically gets prescribed naltrexone, acamprosate, disulfiram. I imagine them having worse disease than the patients, even as much as they might have tried to match the patients, because the outcomes were just worse in those patients that were on the conventional meds, which we know do have some benefit. So I think, and Paul was making this point off air, that the type of patients that get access to a GLP-1 agonist, they're harder to get access to those medications and to be prescribed those. So you're just looking at different groups of people, I think. And that may be part of why this was looking so good for GLP-1 agonists, because maybe those patients just had better resources in general.
Thanks, Matt. I think, so Rahul Ganesh and I were tweeting back and forth about the addiction study, and this was sort of my exact point, is that the patient who has the organization to make it to routine primary care visits and actually obtain a once-weekly injectable medication for which there are multiple insurance barriers for, there are just certain defining criteria that already exist within that patient. That person is markedly different from someone who is not able to achieve those things. So I just there's a lot of intangibles I think are just hard to measure with these sort of retrospective trials, and I don't know that they fully capture the medication effect in and of itself as opposed to the systems that allow that medication to be administered in the first place. And I actually went down a rabbit hole looking at how hard is it to get a GLP-1 in Sweden, and believe it or not, that's actually harder to figure out than you might expect. So it seems like the access is relatively comparable. It's not like they're just giving out like candy there. So, but I just think there's a lot of systemic stuff that goes into access to those medications and capacity for self-care and sort of engagement with the healthcare system in general, that just all those things kind of have to exist for you to even have those medications. And I just think that stuff's hard to measure in these studies. So until we actually, I'm sorry to be talking so much on your part, Laura, but we just did a Curbsiders addiction medicine with Steve Holt on medications for alcohol use disorder, where this point came up, and he's excited too. But until we have the randomized control trial that has this as a primary endpoint, it's going to be hard to know what to do with these data specifically.
Yeah, and I think the researchers do acknowledge that the results of this need to be taken with a grain of salt. And I certainly agree with that. I think we already talked about the fact that it's an observational study, so it can't establish the causality there. And it uses a very interesting within individual model, meaning that the individual basically acts as their own control. So as such, the comparators are different. And the researchers are comparing individuals' risk of hospitalization during periods of use of the medication versus periods of non-use. And so I think there are some promising aspects to this, including that it's a large cohort study. But data is from a registry in one country of Sweden, and these data do not capture all the relevant variables, such as the amount of alcohol consumed, or why patients were prescribed GLP-1 to begin with, or what is their adherence to the medication. So I think I'm hearing a lot of the concerns with the study, and the need for future studies.
Yeah, and it seems like on clinicaltrials.gov there is a randomized controlled trial of semaglutide versus placebo that's going to be done over 26 weeks in people with alcohol use disorder and obesity. So that should give a pretty good answer. And then they're using like liraglutide for opioid use disorder and another one for smoking cessation as well. So there's a bunch of trials with these agents coming out. And
I think dosing will be a consideration, and then because there's also pancreatitis being a specific concern among both populations. There's going to be a lot of sort of tweaking of the data as we sort of
I think it's really not ready for prime time. It's not practice changing yet, and I think there will be a role, I suspect, of GLP-1s to either complement existing treatments for alcohol use disorder or maybe replace them. But I think it's really too early to tell in what capacity. But I do think it's worthwhile considering these results when you're treating with patients with alcohol use disorder plus obesity or type 2 diabetes or something that these GLP-1s are approved for, because that will help with the whatever indication, with the potential added benefit of helping with alcohol use disorder. But I agree, until we have kind of a randomized clinical trial across a broader population, it's not practice changing yet.
There are also a fair number of questions that remain kind of across all of the GLP studies for whatever disease about like the duration of treatment that I just don't. I feel like you're going to have exactly the same problem with this, if not a more serious one, where there's going to be real resistance and understandable resistance to coming off of a medication that's working, but we really have no idea like how long you need to be on this and how persistent the effects are.
Yeah, good point. Good point. Okay, well, we have, I guess, two quick takes on some other recent stuff. Nora, you want to start first with this shorter course antibiotics in sepsis?
Yeah, and this one I actually feel maybe has the best name of the day. So this is the Balance trial, and I'll just read the name and then we can judge the title. So, bacteremia antibiotic length actually needed for clinical effectiveness.
Ooh, Paul.
I know.
I like
it. Yeah.
Bravo. God bless the ID doctors.
Paul, are you crying?
Just a single tear rolling down my cheek. You can't see it at home.
Not a lot of competition for names, but this one definitely beats out for today. Not even close.
Heroes is what they are.
Truly. Yeah, it's the first trial in a long time where I've been like, that is exactly what we're doing here. And so this study was just published in the New England Journal in November and compared 7 versus 14 days of antibiotics in patients with bloodstream infections. And obviously, bloodstream infections can be very serious, and there's a lot of questions and uncertainty around the optimal duration of treatment for bloodstream infections. And so this trial sought to answer those questions. It had a non-inferiority design, and it randomized patients to either 7 days of antibiotics compared to 14 days, which is a relatively standard kind of historical duration of antibiotics for bloodstream infections. And they used a non-inferiority margin of 4% for their primary outcome of death from any cause at 90 days. It was a positive trial, and they found that 14.5% of patients died in 90 days in the 7-day treatment arm, compared to 16.5% of patients in the 14-day arm. And this was supported in both the per protocol and the modified intention to treat analyses, leading to a conclusion of the non-inferiority of 7 days of antibiotics for bloodstream infections. So is this already in the hospitals, Laura? Is this what you're doing?
So I've definitely seen kind of a trend towards decrease in duration of antibiotics. I'm not sure if we're fully there. But I do think this study is very promising, especially given kind of building on so many other smaller trials before it. And I think what's especially exciting about this study is the potential benefits of a shorter antibiotic duration, including the possibility of fewer adverse reactions or events, decreased cost of the actual medication, and possibly decreased hospital stay, and then decreased antibiotic exposure and possible resistance. So I think there's a lot of hope, and I think that this is just kind of adding on some other good studies and data that it may be, shortened antibiotics is where we're going.
Yeah, Nora, just the limitations, just for people in practice before they apply this, the patients were on a couple days of antibiotics. The immunocompromised patients were not included in this either. So this is, you're just sort of standard patient that's in the hospital. Maybe they're super sick initially, but they get better when you put them on appropriate antibiotics within a few days, and they're clinically stable. You feel comfortable stopping antibiotics at 7 days.
Yeah, and I think the other important limitations to note are that they did not include patients with Staph aureus bacteremia. So that's a big note to make. And then also did not include patients who had unintervened upon abscesses, prosthetic joint infections, septic arthritis. So basically things for which you're going to need to treat longer, they didn't include for somewhat obvious reasons. But they did include a number of kind of a pretty broad spectrum of types of infections and sources of infections. 40% UTIs, a good handful of pneumonias, a good handful of intra-abdominal infections, and then a number of different organisms, specifically both gram-negative and gram-positive. So they did try to broaden the criteria for this study away from just gram-negative bacteremia, which had been the focus of the prior smaller studies.
Mm-hmm. And I also hope that future studies will look at some of the excluded conditions, because I wonder if it's possible that this treatment duration may be effective too in those certain cases that we haven't looked at.
All right. To round out the show, we wanted to just highlight, and this was covered, this is patient-collected HPV screening. This was covered by Alyssa Mancini in Digest number 60. Did a really nice write-up on that. And essentially, the USPSTF has right now, maybe by the time this releases, it might be out of draft, but it's a draft recommendation for cervical cancer screening. It's not much change from the 2018 guideline, except they're now saying they're really putting more. We're moving towards, for women 30 and older, we're moving towards HPV testing as the primary method. And you can still do a co-test if you want with the PAP test and the HPV test, or you can just do an HPV test every 5 years. I guess some people will still get the cytology every 3 years if they want to stick with that. But the exciting thing about this is they're now saying that self-collected or patient-collected HPV testing is now recommended. And right now, it's only approved for in-clinic collection, and there's a couple different companies you can go with to do this. But ultimately, I think this is going to be like we can do with FIT testing and the stool DNA testing where that box knocks on your door. And then you supply a bowel movement. This is going to be home HPV testing. So with a self-collected swab, I couldn't really find reason why it wasn't collected or why it wasn't approved, because the evidence from studies says that self-collected at home has good concordance with clinic collected by the clinician. Nora, did you see anything about that?
I'm trying to remember if this is right, but I think the FDA approval was limited.
That's what it was. The FDA did not. Yeah, the USPSTF thought it would be okay, but the FDA has not approved it for home testing yet.
I think that's right. And then there are there's a series of different studies that are ongoing, led by the NCI's Last Mile initiative, trying to look at the different tests that are around and comparing them. But yes, you're totally right. Like all of the studies comparing the at-home and clinic collected swabs have shown good concordance, and so I can't see why. I mean, that's the reason to start using these swabs.
Right.
So
I mean, I think it's just a matter of time. And even if the patient has to be in the clinic to do the self-collected, it's still more patient-centered than having the clinician do it. But What do you think, Paul?
This is the exact point I was going to make. As we made this transition to sort of self-swabbing in general, I think about a resident clinic where you have a resident, a preceptor, a chaperone in the room in the old school days of doing the pelvic examination, the swabbing, and the gowning and the discomfort, as opposed to nowadays you have the patient go to the bathroom with the swab, come back out, and you have answers, as opposed to the patient just declining the exam because it's awkward and terrible, and you're sort of presumptively treating something. So I think the self-collection, even if it has to happen in the clinic, will still lower the barriers enough that many more people will be screened. We'll still have actually things that are actionable. So it's still hugely encouraging regardless of the format, because it's still a step forward. Maybe not, a step forward is not the right way to frame that, but it certainly, I think, will broaden the people who are accepting or sort of willing to go through screening, just because it can be such a burden and it's so personal and certainly very uncomfortable for some. So I think this is a positive, however you spin it.
It's also hard to get into clinic to get this done. So I feel like that in and of itself is a barrier.
Right.
And so making it such that you could literally just go into lab and do it and then go home is amazing.
Yeah. And health systems have population health people that would mail these out to people the way they do with, occult blood testing kits. So I really think that that's the way this will move in the future. And, Paul, with that, I think this has been an episode.
Uh-huh. Do you want to keep going? You're doing great.
No, I think we should go to an outro.
All right. I mean, you're 90% of the way there, but this has been another episode of the Curbsiders, Matt, bringing you a little knowledge food for your brain hole.
Yummy.
This is exactly what I was hoping would happen. Sorry, what was that, Nora? You were going to say something and I cut you off.
Yummy.
There it was. Worth it. Still hungry for more? Join our Patreon and get all of our episodes ad-free, plus twice monthly bonus episodes at patreon.com/curbsiders. You can find our show notes at thecurbsiders.com and sign up for our mailing list to get our weekly show notes in your inbox. That includes this very Curbsiders Digest that recaps the latest practice-changing articles, guidelines, and news in internal medicine.
And we're committed to high-value, practice-changing knowledge. And to do that, we need your feedback. So please email us at askcurbsiders@gmail.com. A reminder that this and most episodes are available for CME credit through VCU Health at curbsiders.vcuhealth.org. And I wanted to give a special thanks to our whole team, Dr. Laura Glick, Dr. Nora Taranto, Dr. Paul Williams, America's PCP, for helping to write and produce this episode, and to our whole Curbsiders team. Our technical production is done by Podpaste. Elizabeth Brodo does our social media. Jen Watto runs our Patreon. Chris the Chew Man Chew moderates our Discord. Stuart Brigham composed our theme music. And with all that, until next time, I've been Dr. Matthew Frank Watto.
I've been Dr. Laura Glick.
I've been Dr. Nora Taranto.
And as always, I remain Dr. Paul Nelson Williams. Thank you and goodbye.